Health Alert is brought to you by OU Physicians in Tulsa. Hello, welcome to Health Alert. I'm Pam Butler. Today we're going to talk about nephrology issues, and joining me is Dr. Pranay Katuria. He is with the University of Oklahoma School of Community Medicine, also OU Physicians in Tulsa, and you're also the Director of Nephrology and Hypertension. Got it all in. Thank you for joining me.
Thank you for inviting me to be part of your show.
Now, we're going to start with sort of framing for our viewers this whole aspect of kidney disease. How big of a problem is it in the U.S.? Compare Oklahoma to what's happening throughout the nation. Tell us a little bit about it.
I think we're going to concentrate on chronic kidney disease because that's what happens to the general public.
Okay.
Recent statistics have shown that 1 in 7 Americans suffer from chronic kidney disease. We carry out annual surveys to look at the health of the general population, and blood samples are collected from select members of the population, trying to concentrate on minorities as well. And these are analyzed to give a guesstimate of the prevalence of different diseases. One of the diseases that's looked at is chronic kidney disease.
Okay.
And the last such survey that was done, that's called the National Health and Nutrition Evaluation Survey, found that 1 in 7 adult Americans suffers from chronic kidney disease.
Let me ask this question then before we even look at Oklahoma. When you say 1 in 7, to me that seems a little bit high. Tell us the difference between, because you're saying chronic, what's the difference between acute and chronic? Because some people may not really understand that distinction you're trying to make.
Acute kidney disease is basically a sudden decline in kidney function. Chronic kidney disease is when the decline in kidney function has been for a substantial duration of time, typically lasting more than 3 months. So someone comes in, for example, after getting dehydrated to the hospital, hasn't had anything to eat or drink and has been having, say, diarrhea, doesn't get enough blood to the kidneys. The kidney function will decline temporarily, and that's called acute kidney injury. Of course, there are about 1 million causes of acute kidney injury. Can happen after surgeries, can happen with various infections, can happen as a consequence of medications.
Okay.
Most cases of acute kidney injury will resolve on their own. Some of the patients might need help with dialysis or other means to correct what's going on in their bodies. Chronic kidney disease, on the other hand, tends to be a different spectrum. It's a slow, typically progressive kind of disease, wherein there is a drop in the ability of the kidney to clear the blood of its wastes. So we have a drop in what we call glomerular filtration rate, which is an estimate of kidney function. And most of these diseases tend to be progressive in nature.
Okay, let me ask this question. In Oklahoma, and I'm going to get back to what you just said, in Oklahoma, are we kind of mirroring the national average?
We are about where the national average is, but we're probably seeing a slightly different mix as compared to the nation. Across the country, about 300 out of 100,000 people carry the diagnosis of chronic kidney disease.
Okay.
This is against what the surveys have been done. The surveys are done on healthy patients or healthy populations, and the statistics are generated based on blood samples that have been collected.
Okay.
300 out of 100,000 people are diagnosed with chronic kidney disease means that they carry a diagnosis of chronic kidney disease.
Okay.
In Oklahoma, the incidence is about 330 to 350 per 100,000 people having chronic kidney disease. We probably have a slightly higher incidence of diabetic kidney disease as compared to the rest of the country.
Okay.
We run at about 50% as against 42 to 45% across the nation.
Okay, and in our other segment, we're going to talk more specifically too about diabetic kidney disease and hypertensive kidney disease. Let me ask this question in the general kind of thing. Do people tend to, you talked about dehydration and going to the doctor or getting to the hospital when you might be very dehydrated and things like that. Do we tend to know that we're getting into trouble? Because sometimes you feel dehydrated, especially during the summer months, or you're not drinking enough. I mean, are those things that can lead us into acute and then chronic kidney disease? Is it the environment as well, like pollutants or things such as that? That's a lot, I know.
That's a very hard question to answer.
But what do you think, Doc?
Getting dehydrated, everyone gets dehydrated
Right.
off and on, maybe because of the weather or because of fluid losses from their body. However, it's extreme amount of dehydration that causes it, or you have an underlying problem that sets you up for it. You might be taking medications that make you more susceptible to get kidney damage from dehydration, or you might have underlying pre-existing kidney disease that makes you more susceptible. Patients with heart disease, if they get dehydrated, probably are more likely to get into kidney problems than someone who doesn't have such problem.
Okay.
So making a determination on how you're feeling sometimes is hard, but most run-of-the-mill dehydrations, if I may use that term, should correct by themselves. Our body tells us, hey, we're getting dehydrated, you need fluids, you need to get out of the heat.
Okay. Now let me ask this question. Is kidney disease, because we hear that a lot about other kinds of diseases, is there a genetic link to it at all in terms of if you look in the family history, other people may have had chronic kidney disease? Is there anything related that way?
Absolutely. Chronic kidney disease can run in families. We do find, even for diabetic kidney disease, which is the largest cause of chronic kidney disease, we found certain genes that predispose family members to getting the same kind of diabetic kidney disease. We also have certain kinds of kidney disease that are handed down from parent to child. For example, something known as autosomal dominant polycystic kidney disease.
Okay.
Where the kidney gets filled up with cysts, which eventually compress the normal architecture of the kidney. About 3% of the people who go on to dialysis suffer from autosomal dominant polycystic kidney disease. Okay. This is probably the most common genetic disease we see. It is not obviously the only one we see.
Okay, let me ask this then. If you have this pregenetic predisposition for this, like what you just mentioned, are there tests that you do in infancy for infants? I mean, is it something that can be detected early where people can then make certain kind of changes or try to slow it? Is there anything like that?
Are we referring to diabetic kidney disease?
No, autosomal, for instance.
Autosomal, really, there's nothing you can do. You can sit and blame your parents for passing a bad gene on to you.
Blame them for something that's legitimate, right?
Absolutely, but there's not much you can do about it.
Okay.
In fact, the only way to pick it up in infancy or childhood is to do gene studies. Later on, by the time the person reaches the age of 20, you can pick up cysts in the kidney by radiological imaging like CAT scans or ultrasounds. Most important is healthy lifestyles, controlling blood pressure and not gaining too much weight, I guess, with most kidney diseases.
Okay, well, what we're going to do, doctor, is take a really quick break, and then we're going to come back and talk about some specifics, like you mentioned, of for diabetes, the chronic kidney disease, and hypertension, and what do you as a physician do to help us to control or cure? People always want to know if there's a cure, but we'll talk about that.
Sounds good.
Please stay put. We'll be right back.
Did you know that getting up and getting active for just 60 minutes a day is all it takes to help you get stronger, look better, and feel great?
Or that fresh fruits and veggies aren't just healthier and crunchier, they can taste better too?
Eating better and getting more active is easier than you think.
Yeah! Keep watching for some fun and easy ways to discover the magic of healthy living in your life.
America.
Let's get healthy together!
Pants, pants, pants. I am folding the pants. Do they go on my head?
Everyday moments can become teaching moments because learning starts long before school does. Give your child the start they need at bornlearning.org.
Welcome back to continue our discussion talking about nephrology and chronic kidney disease. Joining me again is Dr. Pranay Katuria. He's with the University of Oklahoma School of Community Medicine and OU Physicians in Tulsa, and you're the Director of Nephrology and Hypertension. Let's jump in because this is really getting interesting. Now, diabetic kidney disease, can we start there? Because diabetes is something that's increasing, especially among our youth, correct?
Absolutely. I think if you look at what's happened over the ages, the size of the population or the weight of the population has progressively increased, and younger and younger people are getting affected by type 2 diabetes. Previously, in children, we only saw type 1 diabetes, but now we are seeing type 2 very, very commonly. I just looked at some statistics. About 10.4% of our adult population in Oklahoma is diabetic.
Wow.
And about 40% of people who are diabetic will eventually go on to develop kidney disease.
That is frightening. Now, with our youth, because then if we're having this increase in diabetes among our youth, then we're going to start seeing earlier cases of, in terms of the lifespan, of kidney disease.
Absolutely, and we've started to see that. I'm just managing a young man. He turned 30. He became a type 2 diabetic at the age of 15. He is extremely obese, and now is looking at starting dialysis because of very severe damage to his kidneys from uncontrolled diabetes and hypertension.
Okay, now let me ask this, because in our last segment, I'll tell our viewers now, we are going to have one of your physician assistants is going to come and talk about diet and management and control and those issues. So I want to let people know that is up and coming. But with the diabetes, with hypertension, and hypertension, tell us what hypertension is, and then tell us how this is really directly affecting the kidney, because as a diabetic, we all know about insulin. And people may think, well, what does that have to do with my kidney? So help us make those connections.
Well, it's not just having high blood sugars. It's a whole quantum of things that happen in the body in a diabetic that start affecting the kidney.
Okay.
In fact, in the initial phases, the kidney hyperfunctions, goes through a phase of what we call hyperfiltration, where it's working very, very hard. And it's not because of a lack of insulin. In type 2 diabetics, as you well know, there's insulin resistance. And along with insulin resistance comes some growth factors and what we call substances that will increase the kidney's filtration. This actually, to put it in a very simplistic fashion, overworks the kidney and starts to cause damage.
Okay.
You start getting leakage of protein, which causes thickening of membranes, both as a consequence of the leakage of the protein as well as the sugars attaching to the membranes. Eventually, the kidney becomes sclerotic and stops functioning totally. Okay. High blood pressure works hand in hand with diabetes, or in non-diabetics, it can also cause damage. If you look at high blood pressure in a slightly different way, you know, we need a certain amount of blood pressure to perfuse our body organs.
Right.
It gets a little too high. It may be acting like a sledgehammer to actually destroy the internal organs. So a person who's had uncontrolled blood pressure, and it doesn't need to be sky-high blood pressures, it could be just slightly elevated, but for a protracted duration of time.
Okay.
Will eventually cause thickening of the blood vessels that perfuse the kidney and eventually decrease the blood flow to the kidney.
Okay, let me ask this question, because you made a very good point that it doesn't have to be extremely high blood pressure. Clarify for us what is considered normal, what's borderline, and what tends to be high, because people, and then can you tell? I mean, we know it's called a silent killer, but there are a lot of people out here will say, oh, I could tell if I had high blood pressure.
You ask a question that's very, very hard to answer. We go by population definitions of high blood pressure. You know, we talk about a blood pressure less than 130/80 being so-called acceptable.
Okay.
Less than 120/80 is normal blood pressure. We start treating high blood pressure when the readings go above 140/90, unless
Okay.
you're diabetic or have certain other diseases. But this is based on measurements done on millions of people.
Okay.
What happens if you start out in life and you maintain a blood pressure of 110/70, and now your blood pressure is running at 130/90? It's yet in the normal range if you look at it from a population standpoint. But is it normal for your body?
Excellent points.
So we are moving medicine forward to look at what happens to an individual and not generalize it from a population standpoint. But we are far from that point today.
And that's good for people to know, because sometimes people will think that I may be okay if it's at this range, but for you it still could signal an increase.
Absolutely.
Now, how often should people have their blood pressures checked?
For a person in good health, once or twice a year. Everyone should go for an annual physical examination once a year. And maybe one more time during the year, maybe even at a supermarket, except you got to sit down for 10 minutes and use the machine appropriately. You can't walk up to the machine and stick your arm into that automated cuff at a drugstore or supermarket. Sit down for 5-10 minutes, relax, insert your arm, and then check your blood pressure. Repeat a reading after 5 minutes.
Okay.
If you find it to be abnormal, go and get it checked out by your healthcare professional.
Okay, now if we do end up with chronic kidney disease, are there some things you can do, or acute moving into that, are there some things that you can do to reverse it, medications, control it, or is it just boom, dialysis, and that's the only choice?
We have a lot of medications that can slow down the progression of chronic kidney disease. Most of those medications focus on reducing blood pressure, keeping your blood sugars under good control, keeping cholesterol and lipids under excellent control. Remember, most patients with chronic kidney disease will not go on to dialysis. Most patients with chronic kidney disease, however, have a very high risk of having a cardiac or a heart event or a stroke happening to them. So actually, chronic kidney disease is probably the biggest predictor of a cardiac event in the future. So a lot of what we do is what a cardiologist would be doing. Reducing the blood pressure, using specific medications that have been shown to be beneficial in protecting the kidney, like ACE inhibitors or angiotensin receptor blockers, which have benefit in slowing the progression of kidney disease while lowering the blood pressure. In addition, we like to keep the cholesterol, or the bad cholesterol, LDL cholesterol, below 100. We try and get the hemoglobin A1C, which is an average of the blood sugars for 3 months, to less than 7 or even 6.5 in some patients, to slow the progression. We look for reversible causes as well. We can't blame every diabetic to have diabetic kidney disease. We look to see if there's any obstruction to the drainage of urine. We look for other causes that might be affecting the kidney and try and come up with a definitive diagnosis so we can tailor treatment to the needs of the patient.
And to be able to treat that. Thank you so much, Doctor, for joining me and for explaining that. And as I told our viewers to stay put, because we're going to now talk about diet and what we can do to help ourselves either help slow it, prevent it, or control it. Thank you so much for joining me.
Thank you for inviting me.
Please stay with us. We'll be right back.
Up to 40% of businesses never recover after experiencing a major disaster. Make a plan at ready.gov/business. Up to 40% of businesses never recover after experiencing a major disaster. Make a plan at ready.gov/business.
Welcome back. To complete our discussion talking about chronic kidney disease, joining me is Holly Shallop. She's a physician assistant at OU Physicians in Tulsa. Welcome to the program.
Thank you for having me, Pam.
Now, tell our viewers, before we start talking about this area of diet, what is the distinction between a physician assistant and the physician? Sometimes people are confused.
Certainly. Physician assistants work as an extender of the physician's services, and so we work collaboratively with the doctor on routine cases, stable patients, and the doctor actually works on the more complicated patients, but it is a way to extend the physician's services and provide more care.
Okay, and you're always in consultation with the physician Because sometimes people may say, well, I went to the doctor and I saw this physician assistant. I don't know why they gave me that person. But you're doing the same skill set, and if you need assistance or collaboration, etc., you're still in close consultation with the doctor, even on a routine kind of visit,
Yes,
correct?
that's correct. All of our cases, at least in our clinic, I've discussed with our nephrologists, and they are in very close contact and know exactly what's going on with the patients.
Okay, now let's look at this area of diet. Dr. Couture did an excellent job talking to us about chronic kidney disease and diabetes and hypertension and its effect on the kidney and the different things such as that. The area I want to focus on with you is this area of diet. How does diet affect or relate to kidney disease?
Well, diet is one of the cornerstones of management for kidney disease, especially chronic kidney disease. We think about the common causes of chronic kidney disease being hypertension and diabetes. And some of the most important pieces to managing those comorbidities for hypertension, we want to make sure that the patient is limiting their sodium consumption, so limiting the salt in the diet. Specifically, we like our patients to limit their sodium consumption to 2,000 milligrams daily or less. So basically, we want them to eliminate the salt shaker. We want them to avoid salty or high sodium foods such as frozen dinners, fast foods, salty snacks, this type of thing.
Okay.
Studies have actually shown that managing hypertension with the low sodium diet and medications as needed can help delay the progression of kidney disease, and that is our goal.
Okay, let me ask you on this sodium thing. What about soda pops and juices? I mean, we should become consumers where we're actually reading labels, etc. And sometimes when you read labels of things that you think are healthy, they have very high sodium contents. But so what about things such as that?
Well, we like all of our patients to look at their food labels. As a general guideline, we like people to stick to products that have less than 200 milligrams of sodium or less per serving. And to answer your question about sodas and juices, generally water is best, and that's what we recommend.
Okay.
As a rule for patients when they're shopping in the grocery store, we suggest actually sticking to the outer perimeter of the grocery store rather than shopping a lot in the aisles. On the outer perimeter, you have low sodium foods like produce, your dairy section, fresh fruits and vegetables.
Okay. So if you can get more natural products, like you said, the fruits and the vegetables that are not canned,
Yes.
the fresh, then even though they may have a sodium content, it's still going to be better for you.
Yes, that's correct.
Okay, so there are better sodiums than others. Let me ask you one other question, then we'll talk about some other parts of the diet. You said no table salt and things such as that. Well, what about like seasonal salts? Sometimes we don't think that's really salt, but is that included in what you're saying?
Well, we suggest sticking to more natural seasonings rather than the salt substitutes. Things like Mrs. Dash are going to be a safe option. Garlic powders, onion powders, fresh seasonings like lemon or lime. The salt substitutes can be harmful to patients with chronic kidney disease. Instead of using sodium, many manufacturers replace that mineral with potassium, which can actually be very dangerous to people with chronic kidney disease. And so we generally suggest substitutes like Mrs. Dash or more natural seasonings. Yes.
Now, you just mentioned another area. You talked about the sodium, and you just threw in there potassium, Holly. Tell us about potassium then.
As patients progress towards kidney failure in the later stages of chronic kidney disease, potassium can become problematic in their diet. Generally, in the early stages, this isn't a problem, but as patients begin to progress down towards kidney failure, we generally need to limit their potassium. Potassium is going to come from a lot of fresh fruits and vegetables, salt substitutes, so it's something that we actively work with our patients in clinic when they need to restrict their potassium.
Now, we've often heard a lot about bananas with potassium, having a high potassium content. So that's something in the fresh fruits and etc. That you would steer clear of.
Yes.
Or limit.
It's actually one of the higher potassium foods. The highest potassium food is the avocado, but other high potassium foods are going to include oranges, tomatoes, bananas, and potatoes.
Okay. So early on, should you sort of limit the amount that you have of those? I mean, because bananas can be this big, you know what I mean?
Right.
So should we look at maybe having a half of one or a certain size of one just initially? Or if we love avocado, not eating the whole thing, but a half of it a day? Or I mean, does that kind of thing, modification, help?
Usually, modifying the potassium content of the diet isn't necessary until patients have progressed down the spectrum towards kidney failure, and by that time they're commonly under a physician's care.
Okay.
The most important things to limit early on in chronic kidney disease are going to be sodium, and then also if the patient is diabetic, we would like them to follow a low sugar diet and limit their carbohydrate intake. And modifying the protein amount of the diet is another good. It has been shown to delay the progression of kidney disease.
Okay. Now, would you want people to keep a food diary? We hear about that a lot. Is that a helpful tool for the physician to have in terms of what we really have been eating, to come in and get some evaluation that way? Is that a good idea?
Yes, it's a wonderful idea. It gives us a good indication of how you're eating at home. And it also, I think, brings an awareness to the individual of exactly what they're eating. I think commonly we underestimate how much we eat from day to day. So I think the
Exactly.
food diary is a very good tool.
Well, what about protein meats? I mean, you hear about people who just really, really, really love meats. Is that something that's contraindicated for kidney problems, or if you're starting to get into difficulty, or is the protein okay?
Studies have shown that protein restriction, moderate protein restriction, can help delay the progression of kidney disease. When I say moderate protein restriction, we usually suggest that our patients stick to about 4 to 6 ounces of animal protein or less per day, which is going to be about the size of a deck of cards or a cassette tape.
Yeah, kind of like that palm of your hand thing.
Exactly.
Which is not very much, Holly. And depending on how big your hand is, you might can have more, right?
Right.
Okay.
And the reason that we suggest this is when our bodies metabolize protein, it produces nitrogenous waste that is accumulated in the blood, and the kidneys are responsible for filtering that waste. If our kidneys aren't working as well as they could be, that can become problematic, and the nitrogenous waste can accumulate in the blood and can make you feel very sick.
Okay. Well, thank you so much. We've got no potassium or limit, the sodium, and the protein.
Yes.
Thank you so much for joining me.
Thank you.
Well, that's our show. For Health Alert, I'm Pam Butler. I'd love to hear your questions, comments, or suggestions for future shows. Please write me at Health Alert USA, P.O. Box 50913, Tulsa, Oklahoma 74150. Or if you're on the email trail, please email me at healthalertusa@gmail.com. And also visit me on YouTube at youtube.com/HealthAlertUSA. And remember, watch your diet, know about your history in terms of genetic and familial kinds of things, and take care and moderate. Take care. Health Alert is brought to you by OU Physicians in Tulsa.